You went to the doctor. You got a diagnosis. You started the medication and you thought, finally, this is going to fix it. Oh, it's going to fix it. But 6 months later, you're still waking up exhausted. The weight still won't move. Your brain is still foggy. Your hair's still falling out. And when you go back to the doctor and tell them you don't feel well, they check a TSH, tell you everything looks fine, and just send you on home, right? Here's what nobody told you. For a significant number of women, levothyroxine alone is not enough. Not because the diagnosis is wrong, not because the dose is wrong, but because the type of medication is wrong for how your body actually processes thyroid hormones. Okay? That is what we're covering today. And it may be the most important conversation you have about your thyroid health with your doctor. Stay tuned. I want to welcome you back to the Unconventional OB. My name is Dr. Tashima Fair, OBGYN and hormone health strategist, and this is part 3 of our 4-part series on thyroid dysfunction and your metabolism. In part 1, we covered subclinical hypothyroidism and why standard testing fails so many women. Part 2, we went deep on Hashimoto's, the autoimmune root cause behind most hypothyroidism cases. If you haven't watched those, the links are in the description below. See, they set the foundation for what we're talking about today. It's all about medication. It is all about medication. We're talking about the T3, T4, combination therapy, natural desiccated thyroid. We're talking about what the research actually says and exactly how to advocate for yourself if your current medication isn't giving you the life you want. So let's get into it. Okay? First, we're going to talk about levothyroxine and what it actually does. So let's just start with that. Okay? Because most women who are prescribed it don't actually know what it is. Okay? So we're going to get all into it. It's a synthetic T4, it's a lab made version of thyroxine, the storage form of thyroid hormone. It is the most prescribed medication in the United States. And in the right context for the right patient, it works very well. But here's the critical piece that gets skipped in most standard thyroid conversations. T4 is not the active thyroid hormone. Your cells cannot use T4 directly. For T4 to do anything useful in your body, it has to be converted to T3, triiodothyronine, the active form that actually enters your cells, drives your metabolism, your cognition, your energy, your mood, your gut motility, temperature regulation, like everything. So when you take levothyroxine, you're taking a storage form and you're relying on your body to complete the conversion step before any of it becomes biologically active. Got it? And for some women, that conversion step works exceptionally well. Okay? TSH normalizes, symptoms resolve, life improves. Levothyroxine is the right and complete answer. However, for many women, especially those with Hashimoto's, chronic inflammation, gut dysfunction, nutrient deficiencies, or significant stress, that conversion step is impaired. And no amount of levothyroxine dose adjustment will compensate for a broken conversion pathway. Okay? Let's get into the problem. All right, so let's talk about what that conversion process looks like and where it starts to break down. See, the conversion of T4 into T3 is performed by a family of enzymes called deodeogenases, specifically type 1 and type 2. These enzymes removed an iodine molecule from T4 to produce active T3. This happens primarily in the liver, the kidneys, the gut, and peripheral tissues throughout the body. For this conversion to work efficiently, you need some things. You need selenium, which is a critical cofactor for that enzyme, okay, for those enzymes. You need zinc. You need iron, particularly ferritin, in adequate amounts. You need vitamin D. You need a healthy gut lining because a significant portion of T4 to T3 conversion happens in the intestinal wall. And you need your cortisol to be low because chronic stress directly suppresses the enzyme activity. Now, think about the profile for the average perimenopausal woman, like coming to me with thyroid symptoms, elevated cortisol from chronic stress, gut permeability issues, low ferritin, low vitamin D, low selenium. Every one of those factors is suppressing T4 to T3 conversion. She can have a perfectly normal TSH on a standard dose of levothyroxine and still have insufficient active T3 reaching her cells. There is a second conversion problem worth knowing about: reverse T3 or RT3. Under conditions of chronic stress, inflammation, caloric restriction, or illness, the body can shunt T4 toward an inactive mirror image form of called reverse T3 instead of active T3. Reverse T3 occupies the same receptor sites that active T3 needs, blocking them without producing any metabolic effect. It is a biological interference and it does not show up on a standard TSH test. This is why a woman can have a normal TSH, normal T4, and still feel every symptom of hypothyroidism. Her active T3 is low and her receptor sites are clogged with reverse T3. That's why you got to do the lab test. You got to have it, okay? Now, this is why free T3 testing is like non negotiable. Free T3 is the unbound, bioavailable form of active thyroid hormone circulating in your blood. It is the number that most directly reflects what is happening at the cellular level. How much active thyroid hormone your tissues are actually receiving and able to use. Got it? Okay. See, the standard reference range for free T3 is typically 2.3 to 4.2. But here is where I like to look clinically. The optimum range sits at the upper third of that reference range, roughly about 3.2 to 4.2. A woman with a free T3 of 2.5 is technically normal, but she is in the low end of normal, and clinically, she often feels every symptom of undertreated hypothyroidism. And when you look at free T3 alongside reverse T3, you can calculate a free T3 to reverse T3 ratio, a marker of how efficiently your thyroid hormone is actually being utilized. And a ratio below 20 is a strong clinical signal of functional hypothyroidism at the cellular level, even with a normal TSH. This is the information your TSH only testing cannot give you, and without it, your provider is flying blind on whether your medication is actually working. All right? Now, there's some research behind what I'm saying, and we're going to talk about what the research actually shows because this is where conventional medicine and clinical evidence start to diverge. Okay? A landmark study published in the New England Journal of Medicine compared T4 only treatment to combination T4 plus T3 therapy in hypothyroid patients. The result: patients on combination therapy reported significantly better mood, cognitive function, and overall well being than those on T4 alone. Patients actually preferred combination therapy or treatment at a ratio of 2 to 1. Since then, multiple studies and meta analysis have replicated similar findings, particularly showing that women with Hashimoto's and women who have had their thyroid surgically removed have measurably worse quality of life on T4 therapy alone, and show a significant improvement when T3 is added. The second study is a 2019 study in the Journal of Clinical Endocrinology and Metabolism. It found that genetic variations in the enzymes, specifically a variant called T92A, affect a significant percentage of the population and impair T4 to T3 conversion at the intracellular level. Women with this genetic variant show better outcomes on combination therapy compared to T4 alone. This isn't fringe functional medicine. This is a peer reviewed endocrinology research study. The evidence is there. The problem is the speed at which it makes it into standard clinical practice, which historically runs 10 to 15 years behind the research. All right. Okay. So, what are the options when T4 alone isn't enough? Let's walk through those options right now. The first option is synthetic T3. The medication Liothyronine, sold under the brand name Cytomel. This is a lab-made T3 that is biologically identical to T3 in your body and that it will produce through conversion. Liothyronine can be added to levothyroxine as combination therapy, a small dose of T3 alongside the existing T4. In practice, this often looks like reducing levothyroxine dose slightly and adding a low dose of T3, typically in the range of 5 to 25 micrograms daily, depending on the individual response. One practical consideration with T3, it has a shorter half life than T4, roughly 8 hours compared to T4, 7 days. This means some patients notice a more pronounced effect shortly after taking it and a drop off later in the day. And some providers manage this by splitting the dose, half in the morning, half in the early afternoon. And slow release compounded T3 formulations are another option that can smooth out the absorption curve. Okay. Important note: adding T3 to your regimen requires careful monitoring, specifically free T3 levels and a clinical symptom assessment, and should always be done under provider supervision. This is not a self prescribed situation. It is absolutely a conversation you have the right to initiate with your provider. Now, let's talk about natural desiccated thyroid. This is the second option, and it is frankly underutilized. Okay, it's commonly called NDT. Natural desiccated thyroid is derived from the dried thyroid glands of pigs or cows. And before you get uncomfortable, this is actually the primary treatment for hypothyroidism for over 100 years, from the 1890s through the 1960s, when synthetic T4 was developed and gradually took over as the standard of care. NDT contains the full spectrum of thyroid hormones produced by the thyroid gland: T4, T3, T2, T1, and calcitonin. It is a complete thyroid hormone replacement rather than a single hormone replacement. The T3 and T4 are present in roughly a 4-to-1 ratio, which approximates the natural output of a human thyroid gland. Well-known brands are Armour Thyroid and NP Thyroid, and there are compounded versions available as well. For many women, particularly those who failed T4 monotherapy, those with Hashimoto's, and those with well known conversion issues, NDT produces a quantitatively different response. Patients frequently describe it as feeling like their old self for the first time in years, and the combination of T3 and T4 together with all the co occurring thyroid hormones intact appears to provide a more complete hormonal signal than synthetic T4 alone. Is NDT right for everybody? No. Some people do perfectly well on levothyroxine, but for women who have been cycling through doses and adjustments for years with persistent symptoms, NDT is a legitimate research supported option that deserves a trial under proper supervision. Got it? Why doctors don't use it, more frequently, so the research supports combination therapy and NDT for a significant subset of patients. Now why providers don't use it more and they are still prescribing levothyroxine? There's a few reasons why, and we're going to get into it. First, the TSH centric model. Number one, conventional thyroid management is built almost entirely around normalizing TSH. If TSH is normal, the case is managed, full stop. The model doesn't account for poor conversion, reverse T3 dominance, or subjective reality of how the patient actually feels. It is a number driven framework in a situation that requires a symptom driven framework. Two, dragging or training lag. Most endocrinologists completed their training in an era where levothyroxine alone was not just the standard, it was considered the only appropriate treatment. The professional societies, particularly the American Thyroid Association, have been slow to formally endorse combination therapy despite accumulating evidence. Doctors practice what they were trained to practice. Third, the NDT controversy. Natural desiccated thyroid has been the subject of ongoing skepticism in conventional endocrinology, partly because it contains T3, which is harder to dose than T4, and partly because its hormone content is standardized by weight, not by direct assay, which introduces some variability. These are legitimate points for careful clinical management, but they have been used to blanket reasons to dismiss NDT entirely, which as factors to manage thoughtfully in appropriate patients. Okay? The result is that women who need more than T4 alone therapy are left untreated. They are told their labs are fine. They're told their symptoms must be something else. And they spend years feeling terrible when there are documented, evidence supported alternatives that haven't been offered to them. Okay, hope you getting what I'm putting down. Now, how do you have this conversation? That is a great question. I'm so glad you asked that question. And here is how you bring it to your next appointment. Got it? Step one, get your complete panel first. Now, before you can advocate for a medication change, you need data. You need a free T3, free T4, reverse T3, and your current TSH. Now, without free T3 and reverse T3 on paper, this conversation is harder to anchor. Two, document your symptoms. Okay, keep a symptom journal for 2 weeks before your appointment. fatigue, brain fog, weight changes, hair loss, mood, sleep quality, cold intolerance, everything. Bring it in writing. Providers are trained to respond to documented clinical patterns. A written symptom log carries more weight than "I just don't feel well." Okay? Step 3, ask directly. Like, my free T3 is in the lower range of normal. Can we discuss whether combination T3 T4 therapy might be appropriate for me? Or, I've been on levothyroxine for a long time and I'm still experiencing significant symptoms. I would like to explore whether natural desiccated thyroid is an option. Or, can we discuss whether I have a genetic variant in the enzyme that affects T4 to T3 conversion? Something like that. Step 4, if your provider is not willing to have this conversation, that is a signal to seek a second opinion from an integrative or functional medicine endocrinologist or a functional medicine provider like myself who is experienced in thyroid optimization. You are not being difficult, you are being thorough. There is a difference, okay? Trust me. So in part 4, that's the final video in this series, we are pulling everything together. Subclinical hypothyroidism, Hashimoto's, medication optimization, and we're talking about a full lifestyle protocol for thyroid optimization for women over 45. Your diet, stress management, nutrient replenishment, gut healing, sleep, and movement. The non negotiable foundations that support everything your medication is trying to do. It is the what do I do actually every day video, okay? And I think for many of you, it's going to be the most actionable one in this series. If this video helped you understand why you've been struggling, please share it with someone who needs to hear it. Leave a comment below. Are you on T4 only medication and still symptomatic? I want to know how many of you this applies to. I want you to subscribe to this channel if you haven't already, okay? And I'll see you in part 4. Listen, you were not built to feel this way. And now you have the language to start changing that. All right. So in the meantime, in between time, stay healthy, stay vibrant, and stay unconventional. I'll see you in the next video. Be sure to watch the videos that are coming up on your screen. Peace.